A hearty good afternoon and welcome to the session about Know More What is IVF. We are glad to have Dr. Ramyasree among us today to help us understand the topic. She will take us through that and more in this session today. Doctor, you have the stage.
Thank you. Good morning, everyone. This is Dr. Ramyasree Reddy. I'm a consultant fertility specialist at Apollo Fertility, Annanagar. Welcome to this Facebook Live session. Today, we will be talking about what is IVF. So, the topic has been chosen in such a way so that we spread more information on a treatment that has become fairly common these days because of the rising fertility issues that the people are facing around the world. We know that as many as every 1 in 5 couples is facing issues in achieving a pregnancy. And that is where they're having to approach a fertility specialist to go ahead with various treatment options. One among them being the IVF. So, when do we say somebody is infertile? A couple after marriage is having regular unprotected intercourse for a period of around 1 year and still having difficulties getting a pregnancy. That is when we call it as a infertility. And this is a 1 year period given if the couple age is less than 35 years. And if the woman is aged more than 35, we give a time as much as 6 months. And beyond that, we would like to investigate and understand because beyond a certain age, there are issues associated with the gamete quality like the egg and sperm, etc. So we would not like to give so much of a time in a lady aged more than 35 years. So, before we understand IVF proper, let's understand how a pregnancy happens. As we all know, in a woman, the reproductive system consists of uterus, two fallopian tubes, and two ovaries. If you look at the picture here, this is the uterus, and these are the fallopian tubes, and this is the ovary, right? So, what happens is every month in the first day of the period, when you look at a scan, you understand that there are a certain number of eggs which get recruited to grow in that cycle. What happens is that particular set, maybe around 5 to 6 each side, start to grow. But what happens is beyond a certain time, around 1 week and beyond, you notice that one or two follicles are growing more compared to the others. This is what we call as the dominant follicle. That means one follicle has been chosen to be dominant in that cycle, and that follicle grows to be a big sized one around 15 days of the period. Let us say a woman with regular cycles of 28 to 30 days, 15th day around is the ovulation time. That is when that mature follicle releases the ovum, and that comes out, which is picked up by the fallopian tube. So, once a particular egg reaches a maturity, it is ovulated, and that is picked up by the fallopian tube on either sides. Then, at this fertile period, when there is intercourse between the couple, what happens is semen gets deposited here. This is the cervix, which is the opening of the uterus, and this is the vagina. Here is where the semen gets deposited. From here, the motile quality sperms go into the uterus and thereby into both the fallopian tubes. So let us say when somebody with a count of 10 million has an ejaculation and 10 million sperms are ejaculated here. By the time they go here, they are around 1 million. By the time they go here to the tubes, they are around thousands. And somewhere here where the egg is there, by the time the sperms reach the egg, as many as a few hundreds only reach there. But all we need is one good quality sperm to fertilize the ovum. So the ovum which has been released here goes inside the fallopian tube. The sperm is also going here. So once there is an ovum here, multiple sperms surround it, and one of them succeed to penetrate this zona pellucida and fertilize the ovum. And this thing for this embryo, which forms after the fertilization, stays in the fallopian tube for the first 4 to 5 days of life and thereafter travels back into the uterus and gets implanted in the wall of the uterus. And this is where it will continue to grow. And this space is what is occupied by the fetus. And then we call it a pregnancy. So, here, what we need to understand is there are a few checkpoints at which we need things functioning smoothly. Let's look at the checkpoints in an order. First is the ovary. Here, we need that there should be certain good number of eggs which are growing. So, not only that there should be a presence of eggs, these eggs, according to the phase of the menstrual cycle should be growing in particular size. And by the roughly around the time of ovulation, that is the 15th or 16th day, these eggs, one of them is supposed to have become a dominant follicle, and that should be capable of getting ovulated. That means presence of eggs and egg development should be normal. That is the first checkpoint. Second, the semen which is getting deposited should have a good concentration of sperms, and they should also have good motility and normal morphology. So when a good concentration gets deposited here only, a decent one goes somewhere up to the fundus of the uterus and then into the tubes. So somebody with a very little lower count, by the time it reaches the uterus and the long way into the fallopian tubes, the concentration falls much more. That's the idea. So semen parameters become the second checkpoint. Third, in terms of normal pregnancy, what forms the actual hero of the entire process is the fallopian tube. These fallopian tubes are what form a conduit for both the egg and the sperm, and they are the passage in which there is fertilization happening, and they also nourish the embryo for the initial few days of life. So, this is very important. It has to be open on both the sides, and it should be functionally capable of allowing movement. That means the fallopian tubes have a lining which has something called the cilia, which beat in a certain direction to allow the movement of the egg inside and the sperm inside. So when the sperm goes here, the cilia have to beat in a direction to allow the movement of the sperm inside. And these, from the fallopian tube's outer end, it is supposed to pick up the egg and it is supposed to beat it inward to allow the movement of the egg inside. So third checkpoint becomes the fallopian tube. Now, after the embryo becomes formed and after the first 5 days, it goes back into the uterus, like we have discussed. So, once it goes back into the uterus, it needs to get implanted in the uterine wall. That means the space of the uterus should be good. There should not be any fibroids or any other masses which irritate the lining of the uterus. Apart from that, there should be having good uterine flow. That means the blood flow to the uterine lining should be good. This should allow a good crosstalk between the embryo and the endometrium so as to the endometrium accepting the embryo. This is the fourth level of checkpoint, that is the uterus. Now, once a embryo gets implanted into the uterus, that needs to sustain for a period of 9 months. That means we need to not have miscarriages or preterm labors or things like this. That means the general health of the woman should be able to support the pregnancy and let the pregnancy continue for 9 months of time. That then the fifth checkpoint becomes the general hormonal status and general health of the woman. So these are the five different checkpoints. Let's go through them once again. First being the ovary, the eggs development problems. Second is the semen parameters. Third is the fallopian tube. Fourth is the uterus, and fifth being the general health of the woman. So these five are the general parameters. So we have now understood how a pregnancy happens. Now we need to understand what is it that we do when a couple walks into the clinic complaining of issues having a conception. So, like we have just discussed, we give them information about how a pregnancy happens. We explain them what are the different parameters that are looked into. And then we get a detailed history about how long they've been married, what kind of lifestyle they lead, then how are the women's periods, if there are any general health issues like diabetes, hypertension, PCOD, which causes difficulties in the egg development. We look at thyroid disorders, certain other hormonal disorders also we look into, and then we check how their uh, intercourse frequency has been, whether there are any difficulties doing that, and most importantly, we ask them if there was any previous history of pregnancies. That is, some people could have had pregnancies and might have had abortions, or some people would not have conceived at all. So when somebody has not conceived at all in the past, it becomes primary infertility. And somebody who has conceived in the past but are having difficulty either continuing the pregnancy, that is in the form of having multiple miscarriages or in the form of having uh, one miscarriage and not being or having one child already, and for the second child they're having difficulty, these cases come under the category of secondary infertility. Now, after we get a detailed history about the female partner, we would look at the male partner. We would want to understand how his general habits are, what is his age, what is his BMI status, and if he is into any habits like smoking, alcohol, which have a effect on the semen parameters, if he has had any surgeries from the childhood, or maybe any hernia surgery, anything, any history of injuries, any history of substance abuses. All these becomes very important for us to understand how his general health is, and if he's having any coital issues, any difficulty with having erections or ejaculations. All these become very important for us to understand about the male partner's condition. Once we have a thorough history and understanding about both of them, we would like to check with them if they have initial information about what is fertile period. So, what is fertile period? Let us say a woman has regular periods of around 28 to 30 days. A woman with 28-day cycle ovulates around the 14th day. A woman with 30-day cycle ovulates around the 16th day. So, based on this, for a woman who ovulates around the 14th day, fertile period falls between 11 to 17 days. This is the period at which we advise the couple that they need to have intercourse every alternate day in order to achieve a conception faster. This is how a natural advice is given regarding the fertile period. After this, we go for examination. We look at examination of both the partners, and then there are certain investigations that are required both in the form of blood test and scan in the in female partner and in the male partner. The basic investigation that we like to do is semen analysis, apart from a few blood tests that are required. In semen analysis, we like to look at the concentration of the sperm and the motility and the morphology. These form the basic and most important parameters. These are the semen analysis is done with an abstinence period of around 3 to 5 days from the last intercourse or last ejaculation. So when we look at the semen parameters, we get certain understanding as to where does the male factor stay. I mean, whether he is in the normal category or if he is in the subnormal category and requires some help. So, when we look at treatment of fertility, infertility per se, we have three options. First being ovulation induction and timed intercourse. This is very basic kind of treatment. Second is the IUI, intrauterine insemination. Third is the IVF or ICSI. Now, let us go to understand about what is ovulation induction and timed intercourse. This is very basic treatment where a couple who's recently married and has fairly normal blood tests and wants to plan a pregnancy, we we give them some medications to develop the egg, which will be around period day 1 to 5 or 2 to 6. After these medications, few scans are done to check how the follicle is developing. If the follicle is developing and the endometrial lining is good, around the fertile period, we inform them to have intercourse and we look for conception 2 weeks, 2 weeks later on. This is the ovulation induction and timed intercourse cycle. Now, what is intrauterine insemination? Here, instead of the couple trying on their own, the same way medications are given for developing eggs in the ovaries, and on the day of ovulation, that is where we would have given trigger, and 2 days following that, we call the couple to the center and we ask the husband to give the semen sample. This semen sample is washed in the lab and processed there, where the best quality, best motility sperms are taken, and those are inseminated directly into the uterus. So, when we have discussed natural pregnancy, that is the ovulation induction cycles, semen gets deposited here because of the couple trying by themselves. And in an IUI, the semen is deposited here with the help of a small catheter. So, this distance is bypassed in an IUI, this distance of the length of the uterus. Then, after this, uh, by from here, the sperms move and the egg would have gone here from the ovulation site. It would have been picked up by the tube and it enters the tube. Here, the fertilization happens. This is how IUI works. Now, when couple has various indications for an IVF, which we will be discussing a little later, we go for the treatment of IVF. What is IVF? In vitro fertilization. Here, what happens is, like how we have discussed, there is a fallopian tube which forms the basis for all the fertilization to happen in a natural human body. This tube is replaced by an embryology lab wherein the gametes are handled by the embryologist, where we would have given medications for the female to grow eggs. Eggs will be retrieved, and these eggs will be fertilized by a sperm in a dish inside the laboratory. This is to discuss about IVF in very brief. To understand it more detail, I'll help you out understanding this. So, how does IVF work? Let us say a couple which has a male factor of count less than 5 million, count less than 1 million, etc. Or maybe a female with both fallopian tubes blocked. Like we understood that fallopian tubes are extremely essential, be it for IUI or for natural pregnancy to happen. So when both these tubes have been blocked for various reasons, some infections, tuberculosis, etc., these kind of things could cause blockages. So there is no way that both the sperm and egg can meet naturally in this kind of women, or maybe somebody who has endometriosis and there are thick adhesions which are distorting the tubal relations with the ovary, so the ovum is not going up, or there is endometriotic deposits which is increasing the level of increasing the level of oxygen damage, and it is not allowing the fertilization to happen in these cases, or in women where this partner has conditions like azoospermia, as in where in a semen sample which is ejaculated, we are not able to find any sperms. And when we have looked for this more than 2 times and it has been thoroughly investigated, we come to a diagnosis of something called azoospermia, where there are no sperms in semen. When this is identified, we try to understand what is the cause for azoospermia. In some cases, there could be cause like obstruction in the tubes which hold the semen sample. If it is simple obstruction kind of cases, or in certain kinds of non-obstructive azoospermia, what happens is when the outside ejaculated semen does not have sperm, we go to collect the semen and sperms directly from the scrotal site, from the testis directly. This is done by a procedure called TISA, testicular sperm aspiration. So when we do a TISA and we find sperms in there, we know that this sperm can be used to go to do a IVF procedure, because in cases of IVF and ICSI, we only need, in ICSI in particular, we only need countable number of sperms to do a ICSI. So, in partners with azoospermia, or in people with advanced maternal age, advanced paternal age, high DFI, or in people who have advanced age and require further genetic testing of the embryos. Because in things like IUI and normal ovulation, induction, and timed intercourse, we do not see the egg outside. We cannot understand the genetic makeup of the embryo, because all this happens within the body. The same thing, if you want to understand better, is done in IVF and ICSI. When the embryos are handled outside, we can do testing of the embryos. So when the age advances, we know that the genetic makeup of the egg also differs, and there are more chances of a woman having abnormal genetic material in the eggs. So in these cases, we require to do something called pre-implantation genetic testing. This can also be done only in cases where IVF or ICSI is done. So in these cases, along with some people who are undergoing fertility preservation procedures, who have cancers, various cancers which require them to undergo radiotherapy, chemotherapy, etc. We understand that radiotherapy and chemotherapy have an effect on your sperms, have an effect on your egg count and your ovaries in general. So before they start with their treatment modality, we do IVF and we preserve their eggs and sperms, whichever is required. So in these conditions, we go for IVF. Let us discuss in detail as to what is done in an IVF cycle. So, when a woman has been investigated and has been planned to have an IVF cycle, we inform them that what is the treatment timelines. Somebody is looking for treatment in the next period. They would have been given some pre-treatment, some general medications to improve the overall health. After that, once the woman gets her period, she's asked to come back into the center. We look at a scan to understand how her egg reserve in that cycle is, how many number of eggs are available, which we also call as the antral follicle count. If the antral follicle count is good and the general hormonal parameters that time are normal, we start something called the ovulation induction. This is done in the form of giving injectables. Gonadotropin injections are given on a daily basis, something around, let us say, we start giving these injections around period day 2, for roughly for a period of around 10 days. What happens in this time? We look at how the follicles are growing. When we look at the scan, all we can see is the number of follicles which are increasing in size. Egg is a microscopic structure and that can only be seen under the microscope. So we keep giving the injections according to the response, according to the age, according to AMH and the follicle count that we have seen in the period day 2. Now, In between, once the monitoring is done, the last day we give something called the trigger injection. If trigger injection is given on period day 12, there will be OPU or the oocyte pickup, which happens around day 14. 34 to 36 hours after the trigger injection is when we do the oocyte pickup. Here, what is done is under general anesthesia that day, we try to approach the ovaries using the ultrasound, like how you would have undergone your regular ultrasounds all through for monitoring of your follicular growth on the day of the egg pickup under the anesthesia with a ultrasound, a transvaginal ultrasound sound probe. A needle guide will be attached, a needle will be inserted to it. Let us say this is how ultrasound probe looks like. A needle will be attached to it, and this, without making any cut through the vagina, we enter and pierce and reach out to the ovaries. So if you look here, this is the vagina, and an ultrasound probe is being pushed here, and a needle is there which is reaching to the ovaries. So using a suction pump, the follicles are punctured and follicular fluid is aspirated. So, like we discussed, we can't see the eggs. All we see are the follicles and the follicular fluid. This follicular fluid, once it's collected into the tube, is given into the embryology lab, and the embryologist observes the follicular fluid to find the eggs in them and gives information as to how many eggs have been picked up. This procedure could go somewhere between 15 to 30 minutes. And once all the follicles have been drained and passed on to the embryologist, they observe under the microscope and inform us how many eggs have been retrieved by the procedure. With this, the procedure comes to an end, and this is the daycare procedure. Once OPU is done, after the woman wakes up, we give her some food after a few hours, and then she's good to go back home on the same day. Now, what happens in the lab after the egg pickup is done? Once the embryologist observes under the microscope about how many eggs are available with him, there is a process called denudation of the eggs, which happens wherein the outer covering is all removed, and the embryologist observes under the microscope for how many mature eggs are there and what is the quality of the eggs that have been retrieved. This information will be given by him a little later on. Then, on the same day, the male partner is asked to come to give a fresh semen sample. Once the fresh semen sample is given, uh, the embryologist observes under the microscope and picks up the best quality sperms and does something called ICSI. Now we are jumping from IVF to ICSI. So, what is the basic difference that happens in IVF and ICSI is till this process, it's the same. The eggs retrieval is same, husband giving semen sample is same. If we are doing IVF, what we do, we take a dish in which the semen sample is put in, where the eggs are already present. So the eggs which are contained in the dish, in that semen sample containing a few million sperms is put in there. What happens is, how in the general body, in the fallopian tube, there is one egg which is surrounded by multiple sperms. The same kind of atmosphere is created in a dish inside the lab. This is IVF. And how is ICSI different? In ICSI, what is done is, each egg that we have obtained, this is the egg, with the help of a good quality sperm that is picked by the embryologist, an injection is done. If you look here, injecting the sperm, this is the sperm which is being injected directly into the egg. This is ICSI, intracytoplasmic sperm injection. So you would want to understand what is the difference between IVF and ICSI. So in IVF, what happens is multiple sperms are left to find their way to the egg and penetrate the egg and fertilize them. So the fertilization chance can be somewhere around 80%. In ICSI, what happens is each egg is individually taken and sperm is directly injected into it. And most often, the fertilization failures are much less in ICSI than IVF. After understanding this and after getting good advances in how to do an ICSI under micromanipulator, most centers have now shifted to doing ICSI because fertilization failures can be reduced by doing an ICSI procedure. So, the eggs which have been denuded, let's continue how we go about the further process of IVF ICSI. Now, the eggs which have been denuded, after the husband gives sperm sample under the microscope, the embryologist picks up the best quality sperms and they're directly injected into the egg by form of ICSI. And this are observed the next day for understanding how many have fertilized. And thereon, they are observed around day 3 and day 5 to understand how many good quality embryos we have. A day 5 embryo is called a blastocyst, and this is generally the stage at which the embryo enters from fallopian tube back into the uterus. So what we do, we develop these embryos in an incubator until day 5 stage, and depending upon whether the woman's general hormones in that period are normal or not, we do an embryo transfer. If the general hormones are normal, if you have only retrieved something less than 10 eggs in that cycle, if the endometrial lining is good, we go back to do an embryo transfer in the same cycle, which is called a fresh embryo transfer. So the embryos out, let us say we had 5 or 6 embryos developed out of this IVF or ICSI cycle. Out of these, we select one or two good quality blastocysts and transfer them into the uterus. It is similar to the procedure of an IUI. It is not. It does not require any anesthesia. It's a painless procedure. Hardly takes 10 to 15 minutes. With a full bladder, with the help of a embryo transfer catheter, embryos are placed gently back into the uterus, and thereafter certain medications are given, wherein the woman can continue taking them back home. And 2 weeks after that, we do a test to understand whether or not the woman has gotten pregnant. This is if the transfer is fresh. And there is another kind of embryo transfer done, which is frozen embryo transfer. What happens here is in some women, like hyperresponders who have good number of ovarian reserve, good number of eggs, they develop multiple eggs and their general hormonal status becomes elevated. The general estradiol levels, etc., are elevated. When this hormones are elevated, we cannot go in the same cycle and do an embryo transfer because we will be increasing the amount of estradiol, and we will be putting her at risk of something called the ovarian hyperstimulation syndrome, which can be life threatening, and it's an unwanted complication, not something to put anybody through. So we freeze all the embryos which have developed till day 5 stage. This is called cryopreservation. And these embryos are freezed until when we plan to do an embryo transfer. So once freezing is done, the woman can go back home, and once the next period comes, she can come back to us, and we will plan and prepare her in uterus and endometrial lining for doing a frozen embryo transfer, wherein she comes down on the period first day. We do a scan and blood test. Once we have the go ahead, if we plan that all the hormones are normal and the lining is normal, we start giving her medications to develop the uterine lining. Once the endometrial lining is good enough, we start a different medication called progesterone, either in the form of vaginal tablets or in the form of injection. And once, let us say, if you're doing a day 5 transfer, we give 6 days of injections or 6 days of progesterone supplementation in the form of vaginal tablets. On the sixth day, we do the embryo transfer. This embryo transfer is similar to what we have done in fresh embryo transfer. In the same way, under no anesthesia, just in a 10-minute procedure, embryos are gently placed back into the uterus, and the woman can go back home. And after 2 weeks, she will be repeating her, she'll be doing a blood test to understand whether she is pregnant. So this is how a procedure of IVF ICSI happens, and this is called segmentation of this, wherein in the first month we have done ovulation induction using various gonadotropin injections, and we have done the oocyte pickup. And because the woman has high risk for developing OHSs or the hormonal levels are not supportive, we segment the cycle and we do transfer in a different month called the frozen embryo transfer. I hope I have been able to help you understand how IVF and ICSI are exactly done. And the next important thing that people ask is how safe are these procedures? The gonadotropin injections that are given to you are the general body hormones which are produced, but these are being prepared in a recombinant fashion, and these are bioavailable only for the next 24 hours. That is the reason why daily injections are given. And so, after 24 hours of the last injection, these do not remain in your body, so they are not going to cause any harm. And the procedure in itself is a relatively safe procedure, except for few risks like infection, some amount of spotting, and ovarian hyperstimulation, which has totally not been noticed these days thanks to the safer scientific protocols we have now. And we are able to individualize each protocol as per the woman's characteristics and her egg reserve and her hormones, etc. We have a relatively OHSS free experience, and that kind of risk is also not there. So, the most important thing to understand in any infertility treatment is that time is everything. A woman who is married at the age of 25 years has the luxury of planning things at her own convenience. But these days, with the couples delaying their age at marriage, delaying their age at childbearing, we see more often that couples are coming around the age of 35, married for just 5 months, 6 months, things like that. So at this time, what you need to understand is, I'm not saying you directly jump to IVF treatment, but try naturally. Once you decide to plan having a family, start trying naturally for the first 3 months or something. If it is not happening, please reach out and take help of a fertility specialist who can guide and help you understand what exactly are the parameters that need to be looked into. If any small problems are there, they'll correct those with medications and they will guide you. They'll explain you about what is fertile period and you'll be able to plan things better. And if that does not work out, the next option that is available is IUIs. And when IUI is also not working out, that is the time when IVF or ICSI is done. So most important thing is to plan. And once you decide to plan, take in mind that time is very important, and the biological aging and the ovarian aging can be slightly different. And consult your fertility specialist if you're having any difficulties in conceiving. Hope I have clarified whatever doubts are there regarding IVF. If there are any queries, I'm available. If there are any queries, you can reach out to us at Apollo Fertility. Thank you.